Hello and welcome to Cardiology 101. This is Dr. Shiraz, and today we are going to talk about two very important arrhythmias that are ventricular tachycardia and ventricular fibrillation. Now you might know that these two are the most common complication post acute myocardial infarction, and they are very lethal. They don't give you much time. The problem with these two arrhythmias are they don't give you no time at all. It is do or die. You should start your prompt management at that time or you might lose the patient. So it is very important to know both of these arrhythmias at your fingertips and make the quick diagnosis when you come across this kind of ECG. So first of all, we will start with ventricular tachycardia. How do we diagnose ventricular tachycardia? On ECG paper, what we have is broad QRS complex tachycardia. So differentiated from SVT, that was our narrow QRS complex tachycardia. So this will be our broad QRS complex tachycardia. It will be regular. There would be no P waves. Absence of P waves shows that there is no SA node activity or atrial activity, because these are the ventricular arrhythmias. They are originating from ventricles, so we will not have any P wave. It can be monomorphic or polymorphic. We will talk about only monomorphic VT in this lecture, because polymorphic VT, also known as Torsades de Pointes, we will discuss in the next video, inshallah. So first of all, what we have is our this kind of pattern. These are almost regular and there is no P wave. I cannot find a single P wave in this ECG. This is our you can call it a QRS complex, then it is followed by a T wave and then another QRS complex, and it repeats itself. It's kind of a wave pattern. This is our classical picture of VT. Next up, we have another ECG. If we look at the continuous strip, that is our lead 2, you will see that these are our wave patterns that don't have any P wave and they repeat itself over and over again. Now you can see that they are regular. Our QRS complex is broad. So what do I mean by broad QRS complex? What is the boundary after which we call it a broad QRS complex? Well, the distance between the origin of Q wave to the end of S wave should be less than 120 millisecond. I know this is a lot to take. You should just remember that any QRS complex that is wider than 3 small blocks is called broad QRS complex. You will see this in aberrancy, you will see this in bundle branch block, and you will see in the ventricular arrhythmias. For example, PVC, for example, ventricular tachycardia and ventricular fibrillation. So any QRS complex that is wider or broader than 3 small blocks is called broad QRS complex. These are our broad QRS complexes. They are regular. We cannot see a P wave, and they are monomorphic. So what we call what is monomorphic? You can see that all these waves are of same amplitude or the same morphology. So these are our monomorphic VT. So there is another term called sustained VT or ill-sustained VT or non-sustained VT. So what is non-sustained VT? Any VT, any ventricular tachycardia that starts and ends within 30 seconds is called non-sustained or ill-sustained VT. It settles on its own. Any ventricular tachycardia that stays beyond 30 seconds is called sustained VT. Sometimes in pathological condition, maybe irregularity of electrolytes or some other thing, what we see is 2 or 3 blocks of QRS complexes that look like ventricular tachycardia. We should not call any arrhythmia ventricular tachycardia unless it is more than 3 QRS complexes. Alright, so if we have 2 QRS complexes that resemble VT, we call it duplet. If there are 3, we call them triplets. Alright, so if these QRS complexes persist for more than 3 QRS complexes, then we start calling them VT. Alright, so another thing to notice here is our lead 1 is pointing downwards and our AVF is pointing downwards. So if we have both these leads pointing downwards, this is called the northwest axis or extreme axis deviation. I taught you that in the lecture of axis determination that northwest axis is very important during ventricular arrhythmias. So we see an example here. Another one, same QRS morphology. The QRS complexes are broader than 3 small blocks. There is no P wave and there is tachycardia and they are regular. so we call it VT. So one thing to note here is that sometimes when left bundle branch block is with fast ventricular rate, we can see a similar picture, but we should definitely focus on any P wave, any small flickering of P wave that we can find in any lead. Then we should reconsider our diagnosis to left bundle branch block. So anytime you see this kind of a pattern, this is very classical picture of VT, but you should be aware that fast left bundle branch block can appear in this way. So for example, in this ECG, so what we can see is a pattern similar to VT. We have our broad QRS complexes, almost 3 small blocks, and they are regular and they are monomorphic. So we can say that this is our VT. But if we look closely, what we see is this is our V1 and this is our V6. They are different in morphology from each other, and if we look closely on lead 3, what we see is after T wave there is a small flicker of P wave. Alright, if you zoom in on your video right now, you will see that in lead 3 there are small flickers of P waves. So there is some atrial activity, and the morphology, the overall morphology of this ECG doesn't go with VT. So this is our left bundle branch block. So I am again trying to insist on this point. Whenever you come across this kind of ECG, you should always look for the P waves and try to differentiate fast left bundle branch block from VT. All right. Can anybody tell me in the comments below what is the axis on this ECG? You should comment it down below and I will tell you if you're right or wrong. So next up we have ventricular fibrillation. Ventricular fibrillation again is a very important and lethal ventricular arrhythmia, because sometimes when patient goes into ventricular fibrillation, their ventricle is contracting at the rate of 500 beats per minute, so fast that they cannot even contract properly. So what happens is patient suddenly goes into shock or hemodynamic instability. Patient dies within minutes if we don't start any prompt treatment. So how do we diagnose ventricular fibrillation on ECG? There would be chaotic broad QRS complex tachycardia, again a broad QRS complex tachycardia, and it would be chaotic. So if you go back to this video and see that all VT had a similar pattern and they all were regular and they made a proper wave pattern. But in the case of ventricular fibrillation, you will see a chaotic pattern of QRS complexes. We will see in the next examples of ECG. And those QRS complexes will be irregular and P wave would be absent. Why P wave would be absent? Because there is no atrial activity. The arrhythmia is originating from ventricles. Again, broad QRS complex tells us that the rhythm is starting from ventricles. All right. So this is our normal sinus rhythm. You will see that the QRS complex is of proper shape. It is almost of 2 small block. But in the case of ventricular fibrillation, that you will see there is no proper pattern of QRS complexes. They are chaotic. So you should always focus on the fact that these are chaotic QRS complexes with broad bases and irregular. There is no P wave or no T wave or no ST segment. It is a chaotic pattern. So this is our ventricular fibrillation. So patient presents to you after MI, he goes unstable or he goes unconscious. You should definitely go for ECG and you will see that it is either ventricular tachycardia or ventricular fibrillation. Again, if you see this picture, rhythm is chaotic, rate is chaotic, and our P wave is absent, PR interval is absent. We cannot even differentiate what is P wave and what is T wave or what is QRS complex. If you read this line, ventricular fibrillation is a lethal with no cardiac output, because I told you that when left ventricle is contracting at so high rate, it cannot have time for diastole. It cannot even collect blood to pump it out to the brain or other parts of the body. So patient goes to shock or state of unconsciousness. This again is a picture of ventricular fibrillation. We will take the longer strip, that is our 2. We will see that is a chaotic pattern of QRS complexes, irregular rhythm. There is no P wave, there is no QRS, there are no proper QRS complexes, there is no PR interval or ST segment. So this is our ventricular fibrillation. I hope that you understand this concept. Again, a chaotic pattern of QRS complexes, irregularity, no P wave. So this is our ventricular fibrillation. You should understand both these ECG like you understand the back of your hand. You should never miss these ECGs whenever you come across this kind of ECG, because if you don't, the patient will slip out of your hands and you do not want that. Alright, so I'll see you in the next video. If you have any questions, comment them below and I will be happy to respond to them. Thank you.